Hello, and thank you for watching this program today, sponsored by the American Hernia Society Virtual Library. Uh, we've been talking for a long time about how to manage complex hernias. The question is, should we try to do everything in one operation, or should we stage these complex hernias? It's usually related to the complex infected hernias or something along that line. So today we'll review that. Certainly, here's my disclosures, which are evident, and I've done some work for Allergan as well as the CR Bard, and then I have a lot of nutrition advisors not related to this. Now, the objectives today would be decision making in these complex hernias and reviewing the strategy to optimize our outcome, addressing a single versus double stage approach, and considering how to achieve long-term durable repair. I think if we look at complex hernia repairs, they're clearly here to stay. As you can see from these numbers, here in 2001 we did about 125,000 hernias, and in 2013 350,000 hernias. Obviously, this is related to a lot of things. One is we've got much better technology today, and obesity is probably the biggest factor there. That's certainly our better. Now, if we look at the situation of complex hernias. Where are we with complex hernias? Well, what are the reasons we see these complexities? Certainly compromised blood supply, bridge defects, collagen vascular problems, like this guy's got a AAA and issues related. Certainly the big one I see today in my clinics would be infected mesh, heavy contamination, trying to do a single stage when there's incredible contamination and a sick patient with poor source control, and then the other big one, obesity, no pun intended. Now, if we look at that and we say to ourselves, how do we define a complex hernia? Certainly some of those were complex, but I really don't know. I wish I had an answer here. I would like to say it's kind of like Supreme Court Justice Potter Stewart said when he was asked how to define this threshold for obscenity. He said, it's like pornography. I know it when I see it, and I go, that's interesting. The Supreme Court Justice says that. But anyway, complex hernia, I kind of feel the same way. You know, we don't really, hard to define, but we all know it as a hernia surgeons when we see them. Certainly, grossly infected mesh, lots of dead bowel with obesity, and just obesity with loss of domain. All those fit in that category. Multiple previous repairs, huge fascial defects, and all the comorbidities that go along with it. If you can add up those comorbidities, they certainly fit into that same situation. Now, what are the trends in a complex hernia repair? Well, certainly a preoperative now, if this is an elective case, prehabilitation has become a standard of care. To get these patients ready for the big surgeries, we get them nutritionally ready, metabolically ready, hopefully increase their protein mass and intake to try to get them ready. Try true prehabilitation, walking more, exercising more, whatever we can do to get them ready for a big operation metabolically and physiologically. Technique trends, I think we've certainly seen increased robotic, but probably not in complex too much. Decreased lap, I think we've unchanged open. Most of these complex multiple operation wide defects are done open, even in today's world. Mesh location, we've clearly seen a change there. We've seen increased retrorectus use and a delay or decrease in the onlay, even though with improved methods to minimize and elongate bridging defects is really a big key. Component releases, increases transverse release and decrease in the external oblique release. I think we realize in this nice muscular plane we can get mesh to stay well, and we can do some pretty big hernias with a TAR. Some people argue external oblique release still gives us a better approximation of the rectus muscle and midline, but I think it's debatable, and it's really depending on what the user feels comfortable with. What about the materials? I think we've seen a stable or slightly decreased use of biologics. We've seen the bioabsorbables. They seem to peak and maybe fading now a little bit as people realize that sometimes the long-term outcome of those may not give us the strength we need. And we're seeing increased macroporous polypropylene. No question that's been a major increase, and people are getting more comfortable with it and using it more and more. The concept trades, I think the concept of staging has gone through cycles, and we'll talk more about that as we go through here today. So what are the factors we need to consider when thinking of a single versus stage procedure? Certainly the big one, or one of the big ones, is urgency of the procedure. In elective cases, especially when there's been no source control, we have to be very cautious in doing big single stage operations. In elective surgery, when we've got time to prepare the patient, maybe we can get away with just doing single stage in most cases. I think one of the issues is the extent of contamination. How much foreign body is present? Are you able to remove all the infected mesh? What bacteria are there? Are these chronic? Are these acute changes? Is it intracutaneous or intra-atmospheric fistula? Big difference there. A small intracutaneous fistula usually can be maintained. If you've got an intra-atmospheric fistula with wide open spaces, lots of contamination, that's a tough one to do in a single stage. Is the source control obtained? That's the other big question. If you've got source control and time to plan, you're going to have a much better plan doing a single stage. The size of the defect. What procedures are needed for fascial closure? Are you going to be able to get all the infected mesh and contamination out and close primarily? Sometimes that's a good option with the idea you're going to stage it and come back later and do paid second stage. The external oblique release. Again, if you're going to do external oblique release of the classic old, where you made big flaps, the old techniques, without periumbilical sparing, you've got trouble if you're talking about in a contaminated surface doing external oblique releases, because you contaminate those fields. If you can do it with periumbilical sparing, you can save a lot of that headache. If you're going to do external oblique release with these complex hernias. The TAR is I think been a great movement into this area, in that we're able to place our mesh in a well vascularized muscular plane, which has fewer complications than anywhere else we put the mesh. The retrorectus mesh, the retrorectus repair by itself, it gives us some release, but usually not enough for big repairs. The length of time from the last procedure. And really one of the big issues is how comfortable is a surgeon with a big abdominal wall reconstruction. That's the other would make you urgently, you may need to do a single stage and send them for part 2 if you need to do that. Abdominal wall blood supply. We always worry if they've had, 12, 14 incisions on their abdominal wall, good chance they've lost most of the blood supply to that rectus, or at least a lot of the blood supply that's going to let wound healing take place. And then, of course, comorbidities, obesity, diabetes, immune suppression, sarcopenia, advanced stage, all those things come into play. Now, let's, for this demonstration today, let's talk about a couple of cases. One would be a 50-year-old, these are all done within the last couple of weeks here at my hospital, 58-year-old obese diabetic male with multiple intracutaneous fistula and loss of domain. As you can see, about 60% of his intra-abdominal content are in the hernia sac. As you can see here, he's got multiple fistulas, and actually had these fistulas here in the center of the wound were stable and been there for over a year, and then he acutely developed this second fistula here, which had high output, and he developed renal failure, which brought him in semi-urgent. These up here are about ready to open. As you can see, there's very little left. And then oppose that to this gentleman here, a 39-year-old gentleman with a history of MRSA and infected mesh, which was completely removed. Be cautious when you're told the old op notes to be completely removed. A lot of times there'll still be some mesh in there. It should be removed when you do the reconstruction. And then you got a split thickness skin graft over that open abdomen, as you can see. Now, let's go a little more detail. What are the considerations in our gentleman here with the multiple repairs and EC fistulas? Well, he's got a very large fascial defect. That's a 26 centimeter fascial defect there. That's going to be tough. Now, you'll see the rectus are a little bit balled up there, and that's going to give you 4 or 5 on each side just by itself when you get up here and pull them together. So we have to think about that. Should we be using in a pre-op setting, since he is stable and on TPN? Should we be using Botox now? Should we be looking at a TAR or an external oblique release? Bridging. Are we going to need to bridge this? What's the contamination? Will we be able to get skin coverage? That's a big factor. Multiple comorbidities here, obesity, diabetes, multiple fistulas, electrolyte abnormalities. Could be a nutritional problem, but he's now on TPN. heavily contaminated, no question. What's his abdominal wall blood supply? He's had several repairs, as you can see. And the age and the physical condition. This guy has tremendous sarcopenia. You can see these areas here. He's got fatty replaced. This is L4 or L3, might be even L2. You can see he's got fatty replaced of the paraspinous muscles, but not as bad as we might see. So what our plan here then? Plan A is going to be a probable stage procedure. The guy's got multiple things going on, reasonably urgent because he's now got electrolyte abnormalities from the high output fistula. Our plan is going to have, he had some weight loss already from TPN. We'll probably continue him on a high protein TPN, high protein, low calorie TPN, like we would any of our ICU patients with this situation. It's urgent but not emergent, so you got some time. Our plan is to take down the fistula, reduce the hernia, bridge it with a biologic probable, limit major reconstruction if we have to, but getting skin coverage over that biologic. So that's our plan. So let's look at our next guy here. This gentleman here, 39-year-old trans male. He went from female to male with the history of MRSA infected mesh about 3 years prior, and he had complete removal, as I mentioned. So here it's a little less toxic. We've got we can talk about fascial defect. Here he's got a 23 centimeter fascial defect, not bad at all. So certainly a TAR or an external oblique release. But some would argue maybe just do Botox out here, and you might get enough release there just to end up with Botox plus a retrorectus. So again, that's in our bag of tricks now and starting to be considered. We're waiting for some big prospective trials, but I think soon we'll have some of those to see which patients we might use Botox. So ability to get skin coverage at completion, that is a big issue. In this patient, we may want to use tissue expanders and see if we make sure we can get some skin to cover this. Because when you take out the skin graft, that's not going to be viable to use any of that skin. Level of contamination here, not bad unless we get into trouble and get into it. Being taken that skin graft off, you've got to be very cautious there. History of mesh infection, if all the mesh was gone, you're probably going to be fine. Multiple comorbidities, as we talked about here. Now, so probably a single stage repair. We're going to preoperatively prepare this gentleman. He's certainly got lots of potential here: weight loss, increase exercise, keep his preventing sarcopenia with a high protein diet for a month and walking and exercise as much as possible. But our plan would then be a retrorectus repair with macroporous polypropylene, assuming we don't have much contamination at the time of surgery. A transverse abdominis release, and then skin coverage. I mentioned tissue expanders, so I don't think we're going to need them, but it's always a consideration if you need extra skin. First thing we want to talk about is, I love this quote from John Wooden, is preparation. I like John Wooden as an old basketball coach who was a classic winner there at UCLA when I was there. Is failure to prepare is preparing to fail. And I think that couldn't be better than we applied to hernia surgery. So what are the things we can modify? If we're looking at modifiable factors preventing, look at it, glycemic control, smoking cessation, weight loss, all these things come into play and certainly should be looked at. Prehabilitation is hot. Right now, that is a big, big issue. Look at all these papers published in the last part of 2019, 2020 on prehabilitation. These are not all hernias. This is elective general surgery in most cases. But again, generally speaking, we've got excellent data now showing prehabilitation is well worth your time. Well, now, also we got to remember we got to prevent whatever we can do to prevent the infection. Because remember, in hernia repairs, you get a surgical site infection, you end up with readmission, hernia recurrence, because it either infected a mesh that's in there, then ends up getting yanked, or you got to treat for a long time, or you got a biologic, and then you have the recurrence, and then surgical site infections, and hernia repair, and blah, blah, blah. It continues to go on. We've got lots of data now showing this hernia vicious cycle. So preventing infection is the big key here. What about weight loss? We all know intuitively, and we now have good data. We now have level 1 data on weight loss preventing complications of surgery. That's pretty well known. What about glucose control? Clearly, again, lots and lots of data on this. We know that preoperatively we like to see hemoglobin A1C about 7.5 or less. We can do that. If you can't get it below that, we recommend holding on the surgery until you can get some better glucose control. Again, when you've got time, an elective surgery. How about immediate perioperative? We'd like to keep the glucose between 140 and 180, and we won't bore you with the details of all that data. Well, let's look then at the staging. Well, it got some interesting. There's a lot of 3 papers here by Mike Rosen's group, are very nice. Obviously, one of the best groups in the country when it comes to major hernia repairs. We look here. We got 2007. He writes a nice paper here on single-stage approach to complex hernia, contaminated fields. In the conclusion, they have only 19 patients, retrospective, so very small, very early study, but single-stage treatment of ventral hernias in contaminated fields can be accomplished with low recurrence rate and acceptable morbidity in the extremely challenging patient. Well, that gives us an idea that maybe we can push the envelope a little bit. Well, then Mike publishes this paper here in 2013. Again, a very good paper. And again, this is an excellent group. Now, these people are skilled hernia surgeons. Single stage, single surgeon, retrospective review of 128 patients undergoing ventral hernia repair. Single stage reconstruction of contaminated fields can safely be performed with biological mesh reinforcement. The long-term durability seems a little less favorable than they thought, but again, good data showing single-stage, in this case, biologic mesh. Well, what about this paper, published just a couple of weeks ago in Hernia in 2001? Management of again, Rosen's group, ventral hernia, management of ventral hernia defect during intercutaneous fistula. Now we're on that level of pretty high, very high contamination, short-term outcomes, from the Abdominal Core Health Quality Collaborative. Now, this paper I find very interesting. Keep in mind this is only 30-day outcomes, okay? 170 patients. That's from the Quality Collaborative, okay? So you can see here they've got 106 with small bowel fistulas, 30 with clonic fistulas, 100 of the patients with prior mesh, and various different, about 40% of these patients were treated with biologics, 34 with synthetics. You can see this is the 30-day outcome. Surgical site infections, 18%. Surgical site occurrence requiring intervention, 21%. 19 required reoperation. Now, what are the conclusions in this study? Again, just published a couple weeks ago. Morbidity remains high, most closely related to wound complication. As such, concomitant definitive repair should be entertained with caution. Now we're seeing in this big group, multiple surgeons, maybe we should think about definitive repair at the same time cautiously. Again, interesting, I think very nice data from Mike to show us this. What do we see there? Well, we know that by adding up the comorbidities, like in this paper again in 2013 from Rosen's group, once you get over 3 comorbidities, your risk goes extremely high. 67% of challenging hernia repairs with four comorbidities had surgical site occurrence. Remember, that surgical site occurrence really hurts us when they come about. Maybe these should have been, we could look at these as being maybe after 3 comorbidities, think about staging unless you've got those comorbidities well controlled. And of course, with emergent surgery, we're not able to do that. Well, then, what about this dual stage then? Well, here's a nice paper published in 2016 where they did a dual stage repair of contaminated high-risk ventral hernias, okay? But remember, this was an early return to the operating room. So they did 15 patients with the modified hernia group surgical site staging there, which is a grading system. Then a modified hernia grading system is on the right side of the slide, as you can see. So again, most of these are all grade 3s, okay? Over here, contaminated or clean contaminated. This is a modified hernia or grading system, okay? So they had 6 extra intercutaneous fistulas, 2 mesh infections, 2 infected with fistulas, etc. So you can see there, what did they show? Now this is going back within average of 2 days. So they had 15 patients, got 31 procedures, going back over the first 2 days after surgery, and they got fascial closure in 12 of 15, showing they have a good recurrence with fewer SSIs when they go back and do it in 2 stages. So again, showing us the benefit of 2 stages. So now, what about the mesh? This is, again, a big question now. We got lots of choices with mesh. Biologics, you got to think about which biologic you're using. They're not all the same. Clearly, the 3rd and 4th generation biologics are where you should be looking at. These acellular dermal matrix seem to give us our best results. Now, there are all kinds of meshes out there, as you can see. I mean, we've tried them all. I think we've been at every major trial there is. But when we see erosion from mesh, here's one good example of a heavyweight polypropylene eroding in, causing multiple fissulas. Another one here, clearly heavyweight polypropylene causing erosion. Here's some suture pull through on an acellular dermal matrix. Here's melting away on a porcine product. When it just gets a little contamination, it literally melts. Here we see some pretty good outcomes with some dermal matrix in a big, heavy lady with lots of pus. Still had a viable mesh in there. And then some big PTFE eroding into the belly. So it happens in every mesh. We have problem with, you got to pick your mesh and find those that have the least problems. Now, we've seen lots of data recently about the use of more synthetics for a complex abdominal wall. And this paper recently was published. As you may know this paper, Jeremy Warren, an excellent surgeon from an excellent surgical group in North Carolina in Greenville. And what they did here was publish their review of a retrospective review of a database from 2017 to 2019. 541 cases, big group. 46, you can see what they showed here. Some complications. You can see they got some comorbidities here. They had multiple enterotomies, infections, ostomies, etc. So they had 46 got suture repair, 36 had 38 with biological mesh, 55 with absorbable mesh, and 402 with synthetic mesh. And mesh was extraperitoneal in 97% of these. Interestingly enough here, as you can see, the 402 synthetic meshes have the lowest surgical site infection. You think intuitively, wait a minute, these are complex hernias like they're telling us. Why did they have such a low infection rate as opposed to biologics which have been in there for a while? So let's talk about that. Look at that numbers. We got to be careful how we read this. Remember, most of these are retrorectus, but the key to this is when were they placed. Remember, the retrorectus in the biologic is 60% versus retrorectus in the synthetics 85%. We've just talked about the benefit of that well-vascularized muscular plane in the retrorectus position as opposed to intra-abdominal placement has a higher risk of infection. We also have to look at this and say that this is very interesting. This is in their paper. These are quotes from the paper. Our choice of mesh has changed somewhat over time based on our evolving clinical experience. The majority of these big hernias, etc., were performed, the biologic mesh and the absorbable mesh were performed earlier period of the study. 78% of these cases were performed before 2013. So keep in mind now, we're following data that mesh has been there for 6 to 8 years mostly, okay, the biologic meshes. And here, 49% of the synthetic group were only less than 12-month follow-up. So now we're really comparing apples to oranges. We're comparing a biologic mesh, which has got a 3 to 5 to 6 year follow-up, versus a synthetic mesh, which has got a 12-year follow-up. So we got to be careful of how we look at those results. And I always like this quote by Mark Twain group, popularized by him anyway, didn't make the quote. There are 3 kinds of lies. Lies, damn lies, and statistics. And I think we got to really look at some of these hernias and look at the statistics. Well, how often does mesh really require explants? I think here's a very nice paper from Mike Liang's group in Houston, Texas here, where they looked at open ventral hernia repairs on 400 patients and found about, all with mesh, 6.9% explantation of synthetic meshes. So again, now that's interesting in that it follows along with this retrospective review here of 3,400, and 72% of those that got infected require mesh explantation. Again, rarely do we have to take out a biologic, but commonly have to take out a synthetic if it gets infected. And then we have a HQ database also shows similar work. Now, we do have the meshes are all different, as you can see here. This nice paper out of by Ved Roggenstein, Todd Hennenford's group in Charlotte. You can see the different meshes have different recurrence rates. So when we're talking about recurrence, it's really a different animal. Now, what about recurrence rates in these long-term abdominal wall with some of these biologics? This is from Chuck Butler's group in Houston again. Recurrence at 3 years, 11%, or 14% recurrence at 5 years, which is certainly very reasonable. And that's a nice time frame, 3 years and 5 years for follow-up, 191 patients. So I think either whatever mesh you're comfortable with using, certainly we've got data to support it. Less complicated, less contaminated, probably still very reasonable for a macroporous polypropylene. The more heavily contaminated, we got to think about maybe a more biologic. What we do need to prevent, no matter what we do, is bridging mesh, because we know that bridging the mesh, unless we're doing that purely to allow us to come back for a second stage, has increased complications and independent risk factor for recurrence, and certainly has increased recurrence, about 7-fold enhancement. And these recurrences come back earlier. So in our cases that we talked about, both of them, we talk about spread of the contamination in large planes. If we do the big flaps to get a closure, I think that's a big issue. Bridging is a 2-stage is often required if we bridge, and using the bridge as stage 1. So as we finish up here, what about TAR versus external oblique release in these big hernias that we have to pull together? This is a nice review here that compared those at 25 months, although the 3 to 32 months. Remember, you don't even need to look at a hernia repair unless you got at least 2-year recurrence rates, because recurrence under 2 years starts to go up rapidly. You can't really get them all until we see them. And by 2 years, you're going to know most of them are there. So in this case, what do you see? Surgical site occurrence was 15% after a TAR and 25 to 30% after anterior component release. Recurrence rate 4% for the TAR, 13% for anterior component. So I think in these complex hernias, we probably need to lean more towards TAR. The TARs are such a benefit that we've got a large plane developed with good bilaminar tissue ingrowth with a well-vascularized tissue with preserved rectus innervation. So I think those are very nice factors to have in these big repairs. So in sort of closing here, we can say stage repairs. If we look at more likely CDC class 4 repairs, emergent surgery, you've got inadequate source control, you've got high-grade obstructions. Those are not somebody you want to try to do a single stage repair. Significant number of comorbidities. As we add these up, we're going to increase our risk, and maybe we should be better controlled and then come back for a second day for a second stage. Ability for the patient to tolerate too. If they're old, they're 85, 90 years old and have sarcopenia and comorbidities are multiple, that's not someone you want to do multiple repairs on. But, the question if they can tolerate 2, gentler, easier, maybe better than trying to do it all at once. The key is you've got to keep safe. Keep them safe. Single stage repairs are a big key here. But how often can we do them? If they're non-urgent, most likely you're going to get done. Time for prehabilitation. You got time for weight loss, glucose control, good nutrition, good exercise program. You've got time for that with a single stage if it's non-urgent repair. Ability to use the retrorectus space. If we can use that retrorectus space or even to a TAR, again, that well-vascularized tissue is much less complication, and certainly a single stage repair is cost effective in most cases unless we end up with that infection. So what have I learned the hard way with these? Certainly not staging increasing the complex, especially the urgent emergent. Trying to do them all at one time, very hard. Creating big flaps with high potential. Skin dehiscences, exposing biologic meshes. We've got to keep that moist if it does get exposed. Attempting elective repairs in BMIs over 50. Forget about it. That's all coming back. Do what you got to do to get them out of there urgently. Attempting salvage of some of the infected synthetic meshes. PTFE, you can't salvage. Polyester, maybe, unlikely. Macroporous polypropylene, you can probably salvage in most cases. Inadequate counseling about the family. And here's the big one, not having an exit strategy. Plan B or Plan C, Plan B and Plan C need to be well thought out. You can't just have one plan. Don't be a one-trick pony when it comes to these complex cases. You got to have lots of options. And remember, the plural of anecdote, because your buddy told you, oh, this works for me, that's not data. Really look at the data. Let's go back and look at what we did in our cases. This fella here, the 58-year-old gentleman with multiple fistulas, we actually pre-oped him. We did have some weight loss. It was urgent, not emergent. We had time to get him nutritionally prepared. We did a fistula takedown, reduced his hernia, bridged him with a biologic with about a 4-centimeter gap in that biologic. We had undercoverage there, and you can see we got biological coverage. Here he is at his 3-week post-op visit. So the other fellow here, the 39-year-old gentleman, he ended up with a single-stage repair, retrorectus macroporous polypropylene with a TAR with that 24-centimeter defect. We were able to get skin coverage with that, with just mobilizing what we had. So again, good outcomes there. Here he is, post-op day 6, I believe. So, in our last slide, what can we say? We can certainly say multiple consideration when deciding what staging system to do. Emergent versus elective, how much contamination, what are the comorbidities, and certainly surgeon comfort is a big one. What are you comfortable doing? Remember, you've got to have not only Plan A, but Plan B and Plan C. Prehabilitation is a reality. The mesh materials we talked about already. Again, macroporous polypropylene is the go-to mesh for routine cases. Biologics are probably more useful in the severe cases but you got to pick the right biologics. We don't know yet what we're going to do with these bioabsorbables in these settings. Technique trends, again, don't bridge except extreme cases, and staging is very viable and useful to consider.